Good evening to all. I am Dr. Asavri Sawant, Public Health Specialist at IHW Council, and I welcome you all to this exclusive hypertension awareness series, an initiative by Integrated Health and Wellbeing Council powered by Servier. According to the Indian National Family Health Survey 5 of 2019-2021, it is observed that 21% of women and 24% of men have hypertension. 39% of women and 49% of men in India aged 15 years and over are also pre-hypertensive. May is the National Health Awareness Month recognized every year by the Government of India. May is also the May Measure Month, which is the global campaign by the International Society of Hypertension. Hence, partnering up with Servier and joining the May Measure Month, Integrated Health and Wellbeing Council has organized a month-long initiative to raise awareness on the growing burden of hypertension, to make people aware of the different aspects around hypertension. This live session, we would be discussing on the topic of deliberating the role of public-private partnerships in hypertension care, for which we have a very eminent panelist here with us. I welcome Dr. Shuchin Bajaj. Dr. Bajaj is the founder director of Ujala Cygnus Healthcare and a very experienced stalwart in the healthcare space. Sir, we welcome you to the show.
Thank you very much, Dr. Savri, and thank you for having me here. It's a very important day today. And I'm very glad that we are sitting here and trying to spread some awareness about hypertension on this important day.
Yes, sir. Completely agree. 17th May is the World Hypertension Day. And on that note, let us discuss more on this topic. So, public-private partnerships leverage the strength of each other to improve different areas that are improving access, improving quality, improving outcomes. So, what in your experience are some of the key challenges faced by the healthcare sector in providing effective hypertension care or early hypertension care? Over to you.
There are several challenges, Dr. Savri. As we all know, I think the major challenge is the lack of awareness, which we are trying to counter by sessions like these. Many individuals are not aware of hypertension, its risk factors, and the importance of regular blood pressure monitoring. This lack of awareness can result in delayed diagnosis and inadequate management. There is a 50% or the rule of halves, the 50% rule that we commonly see in hypertension across most geographies. So only 50% of the people suffering from hypertension are aware about it. Out of those, only 50% are diagnosed with hypertension. Out of that, only 50% are treated. And out of that, only 50% are adequately treated. So you can see by the time we have adequate management of hypertension, the ratio goes down very, very low. Less than 10% of all hypertensives are being treated adequately. Then second is, of course, the limited access to healthcare services. We have inadequate access, particularly in rural and underserved areas where we work a lot. And we see how difficult it is for the community to access good quality physicians who can manage their hypertension. This not just hinders management of the hypertension, but also hinders the timely diagnosis and detection of hypertension in itself. Limited availability of facilities, shortage of professionals, long waiting time for appointments, all these contribute to suboptimal hypertension care. Then there are a lot of health inequalities due to socioeconomic disparities, due to health inequities. They also impact the provision of hypertension care. Certain populations, especially low income populations, low education level populations, face very big barriers to accessing healthcare services, including screening, affordability, follow-up, etc. Even if we do start treatment, non-adherence to treatment is a big challenge. Adherence to medication, lifestyle modification, as we all know, all of this is very important for hypertension, not just hypertension management, all non-communicable lifestyle diseases. This is one of the key pillars of the management. But most people suffer with non-adherence due to just simple forgetfulness or the cost of medication or actual or perceived side effects of the medication. and of course the lack of understanding about the importance of long-term treatment. We also face a problem in that we have a fragmented healthcare system, right, which is leads to disjointed care for individuals with hypertension. There's lack of coordination between the primary healthcare providers, the specialists, and the other health professionals. It results in large gaps in care, inadequate follow-up, and missed opportunities for early intervention. One of the biggest challenge that we face in the communities that we work in, as you know, we work in small towns, villages, semi-urban areas. The one of the biggest challenges is the cost of care. The cost of care, including medications, diagnostic tests, health professional visits. These are a barrier, especially because in India, OPDs, the outpatient departments, are not usually covered by any insurance scheme, whether it be private insurance or government insurance like Ayushman Bharat schemes. So, inadequate coverage of these insurance schemes leads to a large out of pocket expense to these patients, which leads to financial constraints, and then, of course, again impacts adherence to treatment plans and leads to suboptimal control. Also, most hypertensive patients suffer from other chronic conditions like diabetes, cardiovascular disease, kidney disease, and all these comorbidities and multimorbidities automatically mean that managing all these multiple chronic conditions is a great challenge in terms of treatment complexity, medication interaction, coordination of care, and the fragmented healthcare system where you don't get super specialists to talk to each other. So the patient may be going to a cardiologist for his cardiac management, to a nephrologist for her kidney care management, to an endocrinologist for their diabetes care management, and then they get a large, stack of documents and prescriptions, which they are absolutely confused about which tablet to take, which not to take. And underlying all of this, of course, is our lack of focus on preventive and primary care. The stress, as I keep repeating ad nauseum at all platforms, the stress in India on, uh, you know, care, which is a fee for service model, insurance based model, that you fall sick, you come to us, you are insured, we treat you, and we get paid either by you or by a third party provider, insurance agency, government agency, whatever. This fee for service model leads to a lot of over prioritization on acute care over the prevention care. So we all know hypertension is preventable, it is manageable if we intervene early, if we do lifestyle interventions, early detection, then this is obviously a manageable disease, a very well controllable disease. But unfortunately, because primary health physicians are not incentivized properly, there is no incentivization for awareness campaigns, improved access, patient education, patient empowerment. So these all kinds of uh, policy interventions need to be made to promote preventive care and to reduce health disparities. And in this today's stress on public-private partnerships, I think is a it can play a vital role in tackling these challenges by leveraging our combined resources, expertise, and innovative approaches.
Thank you so much, sir. That was a very comprehensive solution that you provided. You were able to give us a very clear picture of the ongoing dilemma around hypertension and non-communicable diseases that practitioners are, facing trouble with. So let us communicate more on these that you pointed out one by one. Before moving on to the solutions aspect, we would like to understand a little more that on the grand scheme of things, when you put a similar sort of emphasis on the non-communicable and communicable diseases both, and are considering the entire country where there is rural population as well as urban population and mixed sort of population, how much priority is really given to hypertension care or hypertension prevention? per se in India. When we are considering, we have policies around, polio prevention, we have specialized policies around tuberculosis prevention, and government is actively working towards these, as well as recently they have launched policies on rare diseases that are being strengthened. So are there some government protocols that are around hypertension specifically, so that people are more aware about this? As we all know, hypertension has become such a common problem that in one family, at least one family member is suffering from this. And it is sad to know that this is the reality of our country, that this disease has grown so much in number that it is the new normal now, and people do not even bother to take it seriously, to eliminate it completely or work towards it. It's just part of their life, and it's just a lifestyle disease that is being termed as. So, what would be your thoughts on this?
See, there is a lot of stress on the government interventions, policy interventions, as you say, for non-communicable diseases or lifestyle diseases, as we call them. So, the India Hypertension Control Initiative, which was launched in 2017 and has been expanded to more than 130 districts across 23 states now, is one of the award-winning initiatives that the government has launched. It, of course, complements the National Program for Prevention and Control of Diabetes, Cardiovascular Disease, and Stroke, the NPCDCS program of the Ministry of Health and Family Welfare. But this, the India Hypertension Control Initiative, the IHCI, is now responsible for almost more than 3.4 million people with hypertension taking treatment in government hospitals. So the India government has adopted the 25 by 25 goal, which aims to reduce premature mortality due to non-communicable diseases by 25% by 2025. And one of the 9 voluntary targets includes reducing the prevalence of high blood pressure by 25% in 2025. As I said earlier, we estimate that there are about 20 crore adult Indians with hypertension. And as I said in the last question, less than 10% or less than 2 crore have it under proper control. So having 1/4 of all adults with high blood pressure, which is the most common reason for sudden heart attacks or sudden strokes, I think it is one of the major pandemics that we need to fight. So we do keep fighting infections and the, as you said, the maternal mortalities, infant mortalities, pandemics. These are some of the focus areas for healthcare always. But non-communicable diseases or lifestyle diseases, as we call them, is one of the biggest pandemics that India is fighting. And India, of course, now has the triple burden of disease, as we call it, because we have started growing old before we have become rich, right? Most of the Western nations became old after they got rich. So they could manage all these lifestyle diseases much, much better than us. But we have not gotten rich that much. So we have not been able to eradicate the infectious diseases because our public health systems are not so advanced right now. So we still face the annual epidemics of dengue, of cholera, of other communicable diseases. And on top of that, we have this burden of the hypertension, diabetes, heart disease, and of course, we have the triple burden of maternal and child mortality. So India winning the UN award for the IHCI, I think, is one of the bright points. We won it only last year, this award, and this is under the National Health Mission. So the government, of course, is working, is cognizant of this fact. It is working, but of course, we need much, much more initiatives and much, much more, focused efforts on these diseases as well. But as we all know, government has limited bandwidth, limited finances. It can actually do only so much. So it is up to us individuals to make sure that we take care of our bodies, we recognize what is good for us, we recognize what is not good. And for organizations like the India Health and Wellness Council to spread more awareness about these diseases and disorders, so that more people are cognizant. At least they try to measure their blood pressure. If their blood pressure is high, they at least try to talk to some healthcare professionals and try to manage that. So I think it is a lot to do with organizations like ours also to spread awareness, as well as the individuals to be cognizant of it and start taking care of it. The government, of course, will keep working on it, but till the time we manage to completely control infectious diseases as well as maternal and infant mortality statistics, this automatically will be on a second priority for all governments, whoever comes to power.
Thank you so much, sir. Every time you speak, we are flooded with so much information and we can just go on and on. But as the topic of this discussion is public-private partnerships, so we would want to know that, as you have rightly portrayed, government is doing its bit. There are different organizations who are working towards raising awareness, but still there is a vast need for creating more awareness into the entire system of healthcare in India, starting from the very beginning, from school levels itself, we feel. So, how can private health organizations come together with the government and with its support? Can we have a community where people are more and much better aware about their health in general and are more alert to come forward and get checked on their own, so that the practices that or the initiatives that are not one directional or being pushed on to that you go get your blood pressure checked, but it is coming from the audience itself, from the patients itself, that no, this is something not right and I want to stay fit and I want to get checked. So how can we create this kind of awareness amongst people?
I think this is mostly to do with education. So, if the people are educated as to what is hypertension, what are its risk factors, what is the importance of regular blood pressure monitoring, and that can happen only through joint campaigns, outreach programs, community engagement, promoting healthy lifestyles, encouraging early detection and treatment. So, this private partnerships can work together to create wonders in this, to improve access to healthcare services, particularly in underserved areas. So, this can involve establishing either healthcare facilities or mobile clinics or telemedicine networks to reach remote and rural populations by leveraging our private sector's expertise in infrastructure development and the public sector's commitment to equitable healthcare access. Partnerships can expand the reach of hypertension care, hypertension education, hypertension awareness to a large extent. Also, collaborative efforts between the public and private sector can help fill the gaps in early detection and screening of hypertensive patients. This enhanced screening and diagnosis includes setting up, screening programs, utilizing innovative technologies for early diagnosis, leveraging the private sector's expertise in diagnostic services, supporting research initiatives to develop more accurate and accessible screening tools. Also, care coordination and continuity, I think, is one of the most important parts. So, developing this coordination amongst healthcare providers, including primary care physicians, specialists, super specialists, and paramedics, nurses, by creating communication channels, sharing patient information, implementing standardized care protocols. All these partnerships can ensure continuity of care and prevent the fragmented healthcare that we've been speaking about. Also, adherence support and patient engagement is very important. So, assuring that the non-adherence that we talked about, that is addressed. And how can that happen? This, as you said, how will we make sure that people come forward themselves and say, please check my blood pressure, or please make sure I get medicines on time, or my medicines are over, can I get them, or I've been checking my blood pressure and it is not really controlled. How can we make sure that people come forward themselves? This involves a lot of patient education, counseling, support, collaborating to develop patient-centric programs, ensuring we have enough digital tools that promote medication adherence, lifestyle modifications, self-management, self-care, behavioral change interventions. Uh, the public sector's reach and influence in all of this is unparalleled, right? Where the government can reach, where the state media can reach, nobody can even think of reaching, right? We feel that we are working in small towns, working in semi-urban areas, working with rural population. But at the end of it all, how many districts are we really working in? We have 20 hospitals and around 30 sehat clinics and around a reach of about a million people through our digital initiative. But how much is that really in a country as vast as India, or a world that is as vast with billions of people? We may feel that we are doing large amount of work, but reaching a million people is only a drop in the ocean. So the public sector's reach and influence is quite unparalleled, and that the government has to bring forward and flex its muscles to show that we are really interested about it. And that does not include only patient education and engagement and adherence support. It also includes a lot of policy advocacy and reforms in policy. So if we can have policy changes that improve hypertension care, like increased funding for preventive care, incentivizing doctors more to go towards preventive care rather than just curative sick care that we currently do. Maybe releasing impact bonds and outcome based incentives for doctors, regulatory reforms to ensure affordability and accessibility of medicines, guidelines for standard care practices, disincentivizing unhealthy behavior like taxing sugary drinks, or taxing unhealthy foods, fatty items. All of that, this is very important to make sure that private sector brings its cutting edge technology, brings its research capabilities, brings its pharmaceutical advances in this regulatory framework and the ethical considerations and access to diverse patient populations by the public sector route. So if both of them combine, I think it's a great opportunity for us to make behavioral changes in the population, and to have actually patient led conversations. So I look forward to the day when we two doctors are not chatting about how to do this on World Hypertension Day, maybe a year, 2 year, 5 years down the line. We will have patients and patient advocates leading this conversation on World Hypertension Day, and they'll be the ones talking about how to get more doctors aware about it, and to get doctors to really treat hypertensive patients better. And patients already know what they need to do and what they want to do in the preventive side, on the dietary side, on the exercise side, and they are then educating doctors how to go about it in the pharmaceutical side.
That is an amazing vision, sir, and we hope that gets fulfilled in near future in the coming years, and that is definitely the aim. So you were able to highlight various different aspects, but one thing that I was really curious about, that you mentioned that we have a very fragmented healthcare system, as you mentioned. So we would want to know, how is it different from the Western, more developed countries where they have healthcare problems more in control? How does that vary from India, and should India be adopting any of those to improve our health standards in the country? Should we be adopting, should we be taking notes from the good that they have been doing, and should we then partner up together to reach those sort of levels, or progress? I am not comparing only hypertension scores in India than the West. It is general healthcare system that we are talking about, and I am very sure that you are the right person for this question. So sir, please help us.
So I think we should not be really enamored by the West as such. I mean, there are lots of various healthcare systems in the West. So let us look at healthcare systems in isolation rather than thinking about where they have been implemented. So, for example, the US, which we really look up to and try to keep modeling ourselves on, it has one of the worst healthcare systems in the world by far. And I say it openly. It may be very undiplomatic of me to say it, but they spend trillions and trillions of dollars to achieve healthcare outcomes that are sometimes worse than that of Cuba, which spends like less than 1% of what the US spends. So how does Cuba achieve what the US has failed to achieve? The main the difference in the healthcare systems that we talk about is, are we choosing an insurance based fee for service model where you fall sick, you come to me as a doctor, I treat you, and then I get paid for it? Or are we choosing an outcome based model, a capitation based model, where the doctor gets paid for outcomes, for how many heart attacks the doctor prevented in their practice? The doctor with the least number of heart attacks in their practice gets paid the most. If that were to happen, the doctor would be after your life, asking you to go exercise, you should control your diet, what are you eating, you tell me every day, because I don't want you to get a heart attack, because the day you get a heart attack, my pay gets cut. Unfortunately, right now in India, the day you get a heart attack, the doctor gets paid because they put in a stent or two stents or whatever they do with you. So your incentives and the doctor's incentives are completely misaligned right now. We work at cross purposes. So how do we do that? We see various models in Scandinavian countries. If you see, it's a capitation based model where doctors get paid upfront much higher than what a US doctor gets paid as a base salary, but then they don't get paid too much if you fall sick. The UK based model, the NHS model, where a general practitioner has a certain community under her care, and then she works in her clinic and the community accesses that clinic, and the GP has a certain budget to treat the people. And of course, the sicker they get, she has to treat all of those people in the same budget. So she is incentivized to make sure that the community that she is working with stays as healthy as possible. So they spend as little of her money that is in her budget. So Israel, for example, if you see, Israel has a model where the payer and the provider are the same. So we have four insurance agencies there. So you buy either of the four plans, which is a portable plan, like you buy a telephone number in India. You can choose either of the four or five service providers. uh, you pay them a monthly subscription, and then whatever happens to you, that provider has to take care of it. And to disincentivize them from not taking proper care of you, it is, as I said, a portable plan. So if you don't like this provider, you can switch to the other provider and start paying them a subscription. So what happens in this is that once you buy a subscription plan, then the provider has to treat you in the same amount of money that has been given to them. So they are automatically incentivized to keep you healthy. So they will try their best to make sure that you don't fall sick, because the day you fall sick, they will have to spend money on you rather than taking money from you. So that is why Israel has one of the best screening programs ever. They have the best data mining and management ever. Everything is electronically regulated. They have EMR since the last 15 years, when we were not even thinking of EMR. So now they have enough data to say that, okay, if you're a diabetic, and they have data for the last 20, 25 years in electronic form, they see that if a who are the people who went into kidney failure due to diabetes, and they go back those 20 years and see, okay, you had these five risk factors, out of which if you had these three particularly, all of you have now ended in kidney failure 20 years later. So the people now who have these three risk factors, these companies will be after their lives, that now you have these three risk factors, you are at high risk for going into kidney failure, so you have to control your diabetes, you have to go to the gym, you have to exercise, you have to make sure your diet is fine. So they are actually preventing these, kidney failures, preventing these amputations due to diabetes, because they know who is really at risk. So if we can do something like this, promote preventive care, promote, making sure that we prevent as many complications as possible, that is the way to go. So just doing sick care that we do right now, just doing acute care, I see it is important as well. We don't want people to die of a heart attack, but if you have a heart attack, we have to treat you. But our long term vision has to be that we should not allow you to have that heart attack, we should not allow you to go into kidney failure, we should not allow you to have that gangrene which will lead to amputation. If this is the long term vision of all of us, I am sure we'll be able to treat these NCDs in a much better way.
Thank you so much, sir. With that, we come on to the very last question for this day, as it is World Hypertension Day. What would be your vision for the future? How do you envision future along the lines of hypertension care? What should be those things that are not happening right now should happen? And what are some of the things that are going on in the healthcare system right now that shouldn't continue? So what would be your, vision for the future?
My vision is very simple. I wish to see a future where all treatments are patient centric, patient friendly, empathetic, and actually led by patients themselves. We should have patient care coordinators, patient advocates, patient representatives on all treatment boards, all clinic boards, all hospital boards. Patients should be guiding what they want, where we are going wrong. Right now, the problem is healthcare is delivered by us doctors sitting in our ivory towers. We feel we know the best. We've studied this. We tell the patient, you do this and just go out. We don't even want to answer their questions. We don't want to address their fears, their anxieties. And this is why there is so much of a disconnect between the patients and the doctors. This leads to so much violence, so much, mistrust between doctors and patients. If we can just ensure that we educate the patients enough, we develop and upskill enough patient representatives, ensure capacity building of enough patient representatives to make sure they can come up, and then they can actually be the bridge between doctors and patients and lead all these efforts. I think that is the only way to get rid of non-communicable diseases on a larger scale. We've seen even the best of countries, even the most advanced of countries, struggle to manage this epidemic. As I told you, we see how the US struggles with managing obesity, hypertension, diabetes. They have one of the worst possible outcome rates as well. So that is not really the way to go. Develop more big hospitals, develop more super specialists. I think the focus needs to now change to focusing on capacity building for patients and their representatives, and making sure they lead this effort to control this large pandemic that we are facing.
Thank you so much, sir, for such an insightful session. Thank you so much, Dr. Shuchin Bajaj, for taking out time from your busy schedule and imparting us with a wealth of knowledge and information today on World Hypertension Day. Thank you so much. We would also like to thank our partner, Servier, for partnering up on this hypertension awareness series for this month. With that, we sign off now. Thank you so much. Stay happy, stay healthy.
Thank you, Dr. Savri. It was wonderful talking to you. And I hope
Same here, sir.
all our audience stays happy and healthy, स्वस्थ रहें, मस्त रहें और खुश रहें हमेशा.
Yes,
नमस्कार.
sir. Thank you so much. Bye-bye.